Burkitt's lymphoma is a highly aggressive B-cell lymphoma and the most rapidly proliferating human cancer. It is common in children and adolescents, but accounts for only 1 to 2% of non-Hodgkin's lymphomas in adults. Persons with Burkitt's lymphoma typically have a dramatic clinical presentation, which warrants immediate evaluation, given the characteristically rapid growth of the lymphoma and spread to extranodal anatomical sites, including intra-abdominal organs and the central nervous system. A high index of clinical suspicion is required for prompt diagnosis and early initiation of supportive care. Studies of Burkitt's lymphoma have led to the seminal discoveries of the viral role in tumor development and the hallmark translocation of the MYC oncogene. Genomic studies have shown the presence of mutations in p53 and along the phosphate-adenylynositol 3 kinase, PI3K, signaling pathway that contribute to oncogenesis. More than 90% of children and adolescents are cured with highly dose-intensive chemotherapy, whereas adults are more susceptible to the toxic effects of treatment, and prospective trials have shown that only 75 to 85% of adults have a long-term remission. Studies suggest that the clinical benefit of high-dose chemotherapy may be achieved with the administration of infusions of low-intensity chemotherapy. The lower peak drug concentrations significantly reduce the toxic effects of treatment. Although frontline therapy is highly effective, nearly all cases of recurrent or refractory disease are fatal. Retrospective population-based studies of Burkitt's lymphoma have shown that the incidence of treatment failure among adults may be as high as 35%. Newer and safer therapies are needed. History of Burkitt's lymphoma. Burkitt's lymphoma owes its name to the Irish surgeon Denis P. Burkitt, who in 1958 described 38 Ugandan children with rapidly enlarging facial tumors that were uniformly fatal. He postulated that these tumors were round cell sarcomas and noted the unique combination of jaw and orbital involvement and a predilection for extranodal spread to the adrenal glands, kidneys, liver, thyroid, pancreas, stomach, and ovaries. The histologic appearance was later noted to be identical to that of lymphomas characterized by abdominal masses, and a lymphoid origin was confirmed. A key clinical observation was that cases were confined to defined geographic regions in equatorial Africa, strongly implicating an environmental association with an infectious cause. In this context, the virologists Michael A. Epstein and Yvonne M. Barr successfully cultivated tumor cells from a patient with Burkitt's lymphoma and noted the presence of intracellular particles on electron microscopy that had the characteristic morphologic features of a virus. The eponymous Epstein-Barr virus thereby became the first virus implicated as a factor in the cause of a human cancer. Characteristic abnormalities involving extra bands on the long arm of chromosome 14 were found in Burkitt's lymphoma, with corresponding loss of material on the long arm of chromosome 8. This observation led to the discovery of reciprocal translocations that juxtaposed the MYC oncogene on chromosome 8 and immunoglobulin loci on chromosomes 2, 14, or 22, resulting in deregulated MYC expression and uncontrolled tumor proliferation. The geographic distribution of Burkitt's lymphoma also correlated with regions that are holo-endemic for Plasmodium falciparum malaria, and areas with successful malaria eradication programs did not report this tumor. We now recognize that deregulated expression of activation, induced cytidine deaminase within germinal center B cells leads to MYC chromosomal translocations. Plasmodium infections in mouse models cause prolonged germinal center reactions and heightened chromosomal breaks caused by activation-induced cytidine deaminase. The chromosomal breaks potentially account for the elevated risk of Burkitt's lymphoma in regions with endemic malaria. Epidemiologic variants. We currently recognize 3 Burkitt's lymphoma variants: endemic, sporadic, and immunodeficiency associated. The 3 variants share morphologic and immunophenotypic features, but have different epidemiologic and clinical features. Endemic Burkitt's lymphoma occurs in geographic regions where malaria is holo-endemic, and Burkitt's lymphoma is the most common pediatric cancer in these regions. Historically, Endemic Burkitt's lymphoma involved the jaw, the orbit, or both, but contemporary studies show that abdominal involvement is now more common. It is postulated that jaw involvement is related to poor dentition, which allows EBV to enter jaw marrow cells. The bone marrow may be involved, but frank leukemia is uncommon. Involvement of the CNS occurs in less than 10% of cases, typically manifesting as cranial nerve palsies or spinal cord compression. Endemic Burkitt's lymphoma is virtually always associated with EBV infection, and elevated titers of EBV antibodies are associated with an increased risk. The median age at presentation among persons with sporadic Burkitt's lymphoma is 10 years, with additional incidence peaks at 40 years and 75 years of age. Patients older than 60 years of age account for only 20% of cases, but the incidence in this population is rising. Males are affected 3 to 4 times as often as females, with no racial or ethnic predisposition. Sporadic Burkitt's lymphoma can affect virtually any organ, but often manifests as a rapidly enlarging abdominal mass, with involvement of the ileocecal region that mimics acute appendicitis or bowel obstruction. Involvement of both breasts is uncommon and can mimic inflammatory breast cancer. Involvement of the CNS occurs in up to 20% of cases, and the bone marrow is involved in 30 to 35% of cases. EBV is associated with 20 to 30% of cases of sporadic Burkitt's lymphoma, most often in patients over the age of 50 years. The median age of patients with immunodeficiency-associated Burkitt's lymphoma is 40 to 45 years, and cases are equally distributed between the sexes. This variant most commonly arises in patients infected with the human immunodeficiency virus, HIV, and was the first described HIV-associated lymphoma. Burkitt's lymphoma accounts for nearly 40% of lymphomas that arise in HIV-infected patients and notably occurs in those with relatively normal CD4 counts. The clinical manifestation of HIV-associated Burkitt's lymphoma often involves the gastrointestinal tract and bone marrow. CNS involvement occurs in 20 to 30% of cases of immunodeficiency-associated Burkitt's lymphoma, and EBV is detected in 25 to 40% of cases.